DuPage County and COVID-19. As you can see on your screen, this meeting is being live streamed. And I have a couple of housekeeping things I want to ask of you. First, a heads up to anyone who is here for the first time. In a couple of minutes, I'm going to invite you to introduce yourself, briefly, your name and your affiliation and what brings you here. The meeting is being recorded and it's going to be posted at the DuPage County Health Department website. And those postings are really important. If you have visited there, you see that the meetings that we do here, the discussion and sharing that we have and the deliberating we do is viewed by a lot of people in the time after which this meeting is complete. Ask you to please be aware of background noises and mute yourself when not talking. And during our discussion times, which is going to be most of this meeting, I encourage you to keep your video on as much as you're comfortable to help us get to know each other. Our goal at heart is optimal health and well-being for all our neighbors, where no one is disadvantaged by race or origin or other identity. Thank you for engaging this morning. Now I want to take a second and ask folks who are here for the first time to please take a minute to introduce yourself so people on the call know who you are. And Tim, I know this will be a first for you. And Michelle, I cannot remember if you were with us at the last meeting. So you may have already done this and it just has escaped me. So I want to invite Tim. Tim, would you take a second to introduce yourself?
Yeah. Hi, my name is Tim Ackerman. I am a graduate student at Northern Illinois University, and I am finishing up my master's in public health. The last thing I have to do for it is an internship, and I am doing my internship with David at the DuPage Federation on Human Services Reform. And the project that I will be working on is with Middle Eastern and North African residents in DuPage County and getting them better represented in data collection with COVID-19 statistics or various other ailments, because currently they are not being represented accurately in data collection. So it's not giving us an accurate outlook on what is going on in their population and how we can best address their needs.
Hey, thanks, Tim. And I invite Michelle.
Thank you, David. My name is Michelle Zepeda, and I'm the manager of health and food programs over at Loaves and Fishes. So I've been there for about 2 months now. And what brings me to this meeting is I remember Jane McDonald, before she left this position, was told me many wonderful things about this group. I got to speak with David as well individually and invited me. And, you know, my background is also in public health, and I reside in Aurora, and I'm very familiar with everything that runs in Kane County, but now I want to be more familiar with what are the health equity issues and public health issues in DuPage County.
Thanks, Michelle. Appreciate that. Is there anyone else here that I've missed who's here for the first time? I'm looking at names and everybody else looks like they're pretty well integrated to the group. So, you know, it's been a while since we met. And once again, the world, of course, has changed a lot. And I want to give us a couple of introductory remarks, if you'll bear with me for about 2 minutes. Last weekend, our county and our country set aside a day of remembrance for those who've lost their lives in the United States Armed Forces. During the Civil War, President Abraham Lincoln famously spoke at Gettysburg about the importance of honoring and remembering those who died, and also committing ourselves going forward to our ideals so that war deaths are not in vain. Now I want to move us forward to our circumstances today at this meeting and in DuPage County. More than 1,800 neighbors in DuPage County have died from COVID-19 in the last 2 years. We at heart have been working collaboratively to protect health and promote recovery as the pandemic has raged in waves. Although we're not finished with our emergency response, we are turning to committing ourselves to future work, to heal and to preserve our ideals so that every neighbor has optimal health and well-being and no one is disadvantaged by race, origin, or other identity. Today's meeting begins with 3 agenda items that are looking forward to committing ourselves to those ideas for the long term. And then at the end of the meeting, we're going to turn ourselves back to our immediate circumstances and the immediate response to COVID with a report from the DuPage County Health Department. So thank you for being here to engage in this. Our first order of business is to ask Becky to give us an update regarding DuPage County health rankings and impact DuPage priority areas.
Good morning. Thank you for the introduction, Dave. For those who I don't know, my name is Becky McFarland. I'm the Population Health Coordinator here at the DuPage County Health Department. And one thing that we are starting, Dave mentioned looking forward, is we are at the beginning of a 3-year action cycle in our Impact DuPage Action Plan. So I'm going to talk about what that means. I'm just going to give a brief overview on Impact DuPage. I'm going to talk about some background data that we do have about how we kind of came to these priority areas I'm going to talk about. And then really want to talk about how HEART can become more integrated and involved moving forward, as well as just some challenges we want to acknowledge and discuss that we might face in the next 3 years. And then I just had a quick slide of resources too that we can all look at. So what does Impact DuPage actually do? It's a multi-sector partnership working to create a shared understanding of community needs, priorities, and disparities, and then using those that knowledge to propel actions that improve the well-being of the DuPage County community. So the partnership pledges to be data-driven, collaborative, equity-focused, and accountable. And there actually are a couple members of our steering committee on this meeting as well. So if there's anything that I am missing, please feel free to let me know or join in. So what we do is every 3 years, we we do a process where we complete 4 assessments. And we do 4 different assessments because just one assessment can't tell us everything that we possibly need to know. Probably 4 aren't telling us everything we need to know, but we're getting as close as we can. So I actually wanted to show you, and if you are at a computer that you can click at, you should be able to actually click this link yourself too. But we post those 4 assessments for anyone in the community to view. And so I just want to show you what this looks like. And I probably have to stop sharing and resharing. So bear with me for 1 second while I switch screens. All right, so if you click that link, or if you go to the Impact DuPage website, you will be able to navigate to the 2022 Impact DuPage Community Assessment. So we did a landscape review, which was a survey of community residents. So anyone was eligible to take that. We did offer it in English and Spanish, as well as online and on paper. And this was an assessment that really collects community voices to learn about perceptions of the quality of life. So this was one assessment that really, it collected things like assets as well as things residents wanted us to work on. We also do a local systems assessment. So that's a lot of the people that actually work in the local systems, and that assesses strengths and weaknesses of like how the system works as a whole. And then there's also a forces of change assessment. So this one is different community leaders, and they brainstorm trends, factors, and events that could affect our quality of life moving forward. So those are kind of more focused groups. And then we also do a community profile. So that's like taking all the data the quantitative data, the hospitalization data, things that can tell us about health status, quality of life, and risk factors, things like that. So again, anyone is welcome to click on any of these and read the full reports, but we don't have time for that today. So I am going to switch back to my PowerPoint. Sorry.
While you're doing that, Becky,
Yes.
I want to remind the group that we did a Forces of Change assessment here
That's right.
with the Health Equity and Access Response team.
Yes, thank you for reminding me. All right, so I wanted to quickly just to give you an idea of like data pieces that we might we looked at when we kind of chose our priority areas, and kind of just look at, sometimes we get really great data broken up by race, ethnicity, and sometimes that data just isn't available to us. So sometimes we will talk about that a little bit in the challenges portion of the presentation. But just to kind of orient everyone to the kinds of data we're looking at, in addition to those 3 other assessments I mentioned. So again, we look at just simple percentages. So this one is adults unable to afford to see a doctor. And so that number on the left in black is 9.7%. And then what that does is it compares to the prior value. So this little equal sign just basically means that we're pretty close to what our prior value was. This shows that our trend's going up. And then if there are any relevant targets, this shows if we met those targets or not. So this specific measure that we're looking at right now on the screen was an Impact DuPage target area in 2018. And I explain all that because the other thing that Impact DuPage does is it hosts a website. So impactdupage.org. Any community member agency can go to that website and actually find data to use for grant applications, to talk about community needs and strengths, things like that. So you'll see those symbols on the Impact DuPage website if you go there to try and use our data as well. If anyone has any questions as I'm going through, please let me know too, because I'm horrible at multitasking and I feel like I have like the people's faces, the chat, my PowerPoint. So please just let me know if I'm going
Not a question, Becky, just a comment, which people will probably be acknowledging as they look at this data. We're really blessed to have great sources with voluminous amounts of information that come to us. But what we don't always have is the timeliness that we would like. And so the challenge is that we're often making decisions with data that is several years old. And that's never great. It's especially complicated though when we think about what has happened in the last 2 to 3 years. So much of the data that we're using to guide our decisions right now actually predates COVID. And clearly there are places where having that data would be incredibly helpful. Hopefully as time goes on, we'll get better nationally at being able to get that data in a more timely way, but just to acknowledge that limitation.
Yes, thank you. And you covered a portion of my challenges slide already, so thank you for that. So the next one is just to give you an example of a measure where we do have a breakdown of rates by race, ethnicity. However, again, even though, we're glad that we have this breakdown, it looks a little, I think, hard to interpret. And so I just want to say that there's a caveat when we look at some of these things, because our population size in DuPage County for American Indian, Alaskan Native populations, as well as Native Hawaiian Pacific Islander populations are so small. They're actually just barely above what is even like a reportable level. So what we're allowed to include here. So this could mean that there's multiple, like this one is for age-adjusted hospitalization rate due to adult suicide and intentional self-inflicted injury. So it could mean that there's like multiple admissions for a small group of single individuals, or single admissions, so like one person going one time for like a larger group of people. But I would just say to kind of take those two specific populations and just kind of think about that as we're trying to interpret the data. So Native Hawaiian Pacific Islander is 0.03% of the population in DuPage, and American Indian Alaska Native is 0.27%. So again, just to kind of show you. But what that chart on the right is saying is it shows you the key, that green bar next to the race ethnicity is that population is, their rates are significantly better than the overall value, and red is significantly worse than the overall value. So these are just, again, examples of things that we look at as we're creating our action plan. Another one is just related to teen alcohol. I see something in the okay. Yes, and Kara just mentioned in the chat that depending on the vendor that is actually providing data to the data dashboards, some hospitals interpret the data differently because they have concerns about the small sample size. So our vendor actually gave us the option to remove the populations altogether, but I just feel like I would rather explain what it is and not take it out. But they were like, we can, because it's a small population. So thank you, Kara, for that. And so again, just we pay attention to things like when we're significantly above our prior value, if we're not meeting targets, and if our trend is going up, when we think about which priority areas to address in our 3-year action plan. And again, here's another example of where we have race ethnicity data, but again, you kind of see, you know, that there's, I should also say that this one shows blue means there's no significant difference with the overall value. So even though like here, we're lower than the Illinois value overall for ER visits due to adult alcohol use, when compared to other counties, we are kind of, we have areas of improvement there. Again, hospitalization rate due to adult alcohol use. So this is confusing. The last one was ER rate, this one's hospitalization rate. So they're actually admitted to the hospital for alcohol use is this measure here. And then this one, again, is one where we're just kind of monitoring it because it is increasing over time. So this one is death rate due to drug poisoning per 100,000 population. Sorry, my slides are not advancing. And then again, opioid deaths. So this is an example. Kara mentioned like the timeliness of the data. So oftentimes when we can pull our own local data sources, that is where we're able to get the more timely information. So this one's actually from our DuPage County Coroner's Office. Another example of that is we get data from DuPage Continuum of Care on homeless populations. And so those ones, those data sources are really helpful for us because they, they're more recent than 2017 to 2019. And then this last one is just the cause of death. And again, this is 2020. So it does include COVID, but kind of only like 6 months worth of COVID data. And this is from IDPH, Illinois Department of Public Health, Office of Vital Statistics. And then last one, again, if you are interested in any of this, I will put my email address at the end, but this one is life expectancy by race ethnicity. And so again, even though we are as a county as a whole doing really well compared to Illinois counties, US counties, Illinois value, and the US value overall, and we've stayed pretty consistent, you can see that there are disparities by race ethnicity for life expectancy. And that is from the county health ranking. So I will share some data for that. So as many of you may have heard, DuPage County was ranked the healthiest county in Illinois. And so as we look at those things, we say that's great, like that we want to be the healthiest county, right? But as we look at those measures in a little bit more detail, that to really think about kind of what disparities exist. And I will say that a lot of our data is around race, ethnicity, but we know that's not, the only population we should be looking at. Unfortunately, that's kind of again, we'll talk about this in the challenges, but that's like the data that we have easily available to us at this point in time. So for example, years of life lost, which is basically someone prematurely dying before the age of 75. Although DuPage is in the top 10% of performers for this measure in the United States, even, that, for example, we have the Asian population having the fewest years of life loss and the Black African American population having the most years of life loss when compared to other races, ethnicities. So I know this slide is kind of hard to read. Again, the same thing with the data that County Health Rankings gives us just pulls from the most recent year. So that last bullet point there, the fee for service, Medicare enrollees, that was the data they could easily get, and they took vaccinated for flu. So again, just showing where DuPage overall is in the top 10% of performers for this measure, that 56% of people in that population received flu vaccine, but the disparities by race, ethnicity are that the white population has the highest vaccination rate, and Black African American population has the lowest rate when compared to other races and ethnicities. And if you're curious, I linked the source at the bottom of this slide, and I can also send it for anyone who wants to see all the data sources that they use to calculate the county health rankings. That's through Robert Wood Johnson Foundation and the University of Wisconsin. Population Health Institute, I think is their official name. Someone correct me if that's wrong. All right, so any questions about just that? That was just like so much information. But so
Becky, hi, this is
yes.
Jan Geider.
Sure.
I have a question.
Mm-hmm.
In the prior slide, we thank you. We read here that years of life loss was more significant in the Black African American population compared to other populations. Now, going back a few more slides, would it have been beneficial because I know sometimes information can be distorted or skewed in because of how we present it, to perhaps not include the Hawaiian Asian population to show the significance of how our Black African American population is not faring well. And also in that data, we learned early on, David, in the evolution of heart, that there are Black families out here in DuPage County who basically just live out here. They're self-isolated. And do we have a way of accounting for those families who continue to receive their health care outside of DuPage County to truly reflect the numbers? For example, those in that population who participate with the flu vaccine.
Jan,
Yes.
speaking to your second piece, not the first, it depends on the source, but sometimes there can be the limitation that some data is tracked by the location of the health provider, but more commonly, I think the intent is to track by where the patient lives, independent of where they receive care, which that as we all know, created lots of confusion as we were tracking COVID data, because depending on how the data was being reported, it was sometimes hard to tell whether or not we were looking at rates of vaccination in DuPage or rates of vaccination for DuPage County residents, that it wasn't always the same. But for each of the stats, I know you can look closer and find out which of those two it is. I think that IHA is typically, when they're reporting the data, Illinois Hospital, they're typically reporting the data based on where the person actually lives, not where they receive the care.
Okay. So that data is reflected in IHA source data. Okay, so for example, I'm looking at one now that says county health rankings. Where is that data from?
I'm trying to remember where their original source is. I can't remember where they are pulling it from, but I can email you where it's coming from.
Okay, I'd appreciate that.
Sure.
And one other thing, and I know this is not going to be resolved in this meeting, but I just want to throw this out there because I was in a meeting recently, and it was a physician out of the University of Chicago, and she spoke about the impact of the allostatic load on health and how we don't have a way of accounting for that. And what that is how does stress associated with discrimination impact one's health? And we do have studies that show that there is definitely a negative impact. And I'm guessing, hoping that in the future, we will have some way of, in terms of measurement or metrics of finding, of assigning some kind of equity measure that explains the association of stress with health. Does that make sense?
Yes.
Especially, I mean, when we look at mental health and what we're seeing now with a shortage of mental health workers and widening gaps for the care that's needed in a lot of our BIPOC communities that just isn't there. How do we, again, thinking forward here, how do we begin to address the impact, by numbers on health outcomes in our more vulnerable populations?
Mm-hmm. Yeah, thank you for bringing that up, because I do think that's some of what we're looking for is like, what would we measure? What other measures do we need? And so, like you said, we're not probably going to solve it today, but I think that is where we're moving towards it. I don't know, David, do you have any other?
Well, I had one other thought, Jan. I don't remember if you were with us in December. We did a human services information sharing session on stress and racism, and the statistic that you're mentioning actually is when we measure it, it gives us a hopeful way to move forward, because there's good evidence developing that work to reduce discrimination reduces stress. And so this is a really good place to identify where that is happening. Means we want to put energy into reducing discrimination.
It would also be interesting,
and we
Becky.
do that. I'm sorry, and David, we do that by, and I think it was Mary Keating who said that in an earlier meeting, that we have to look at the systems. I mean, we can't, our approach cannot be in silos, but we have to look at the systems that feed into that kind of racism or discrimination that ultimately impacts, no pun intended, Becky, okay, it ultimately impacts the health of our residents.
Affirm.
And I do see, it looks like we have a hand raised. Are you able to unmute and ask your question or make your comment?
Yeah, it's interesting what we're talking about, and sometimes, being diabetic and everything, I'm in the doctor's office, I'm waiting and I'm watching what goes on. I think the initial problem is when someone comes to the doctor's office and then they're being asked, do you have insurance? And they say if they have insurance, great. They leave them alone and everything. Oh, you're okay. You can sit. And then the one who doesn't and has other forms of whatever they have presenting, then there's a difference right there. That you can see the difference how that patient's being treated. It may be subtle, but it's tremendous, and it's the effect where it could be discouraging to a patient to even go and seek the help they need. So if that's intimidating to patients, patients are why am I going to go there? I'm not gonna. Maybe they're not just, they're going to treat me a certain way because I don't have health insurance. So I think the beginning is there. Maybe some type of training or something where they're not making. I was just with my podiatrist earlier this morning. That's why I was late. But I did see I have health insurance. Great, Oh, okay, you're good. Someone else had Medicaid, and they were asked all these questions and this and that. It probably took that patient 15 minutes to check in. Well, it only took me 2 because of all the questions that person was being asked. So that right there is very intimidating, I would believe, and it's discouraging for people to go to a doctor to seek help.
Yes, I think that is, and I think that is an example of what Jan mentioned with systems change too, is somewhat looking at, how we can change those systems or influence any systems to make them less intimidating there. So there's some comments in the chat, but for the sake of time, I'm going to just move us into our priority areas. And some of these things we will address, and we will have subsequent meetings to talk about this. So I don't want to feel like we're rushing us through, but I do feel like there are things we need to cover to maybe have those conversations. So the priority areas that Impact DuPage will use for their action plan for the next 3 years are around mental health and substance use disorder and prevention and management of serious illness. But because we know some of the data, and because we've had conversations with stakeholders and community members, we know that as we address those things, we need to consider what we're calling cross-cutting issues. So person-centered care delivery. Are we addressing some of those like social determinants of health? I think, the insurance example was a great one where is it meeting the needs of the person who's actually seeking the care or services, and then also achieving equity. So does everyone have those opportunities to live their healthiest life? And I'm just making sure that I'm not missing any questions in the chat. So again, this is just giving some examples of kind of what that person-centered care delivery would consider. And then we talked about this, we talked about some of these points. Kara mentioned the second one of the timeliness of the data, which is maybe where we need to fill in with more local data sources if we have them. I also think we focused a lot on race ethnicity data, but we know and Dave and Tim sound like they're going to talk about this a little bit too, but the race ethnicity data we do have is maybe not the most representative or telling of our populations here in DuPage. And we're also missing other data where people may be having trouble to access healthcare, for example. So like the LGBTQ population, people experiencing homelessness, things like that. We don't have easily accessible data sources around those things. And then I think just like picking areas and focusing and creating shared goals sometimes just is a challenge in and of itself, because there are so many things we can do. But it's come up a lot too that systems level change and policy related change will be really important moving forward for sustainability and just maximum impact. All right, so next steps. We do want Heart to be involved with the Impact DuPage Action Plan, this is our first foray into doing that. Impact DuPage at dupagehealth.org is, those emails go to me, or you can send any ideas or feedback from this initial conversation to me and or Mila. And then we are going to talk about a potential funding opportunity. And so Dave and Kara will talk about that. And then this is just a couple of websites that I found that were helpful. A national network to eliminate disparities in behavioral health, a health equity library for LGBTQ health, and then the What Works for Health County Health Rankings and Roadmap shows interventions that are evidence-based, so like have been studied by science. And then there is a measure in there that says if it's likely to positively impact a health disparity or not. So that information now newly is included in those evidence-based measures this year. And then of course, Impact DuPage website. All right, any last minute questions or comments before we move into talking about the funding opportunity?
Becky, I do have, of course, I have a question.
Sure.
You indicated that you don't have enough data for our homeless population. Are you connecting with our food pantries, for example, Loaves and Fishes? Because they collect great data. And this could be a source, if you're not already doing it, to have a better understanding of how many of our residents are having, housing insecurity, food insecurity, etc. Are you currently doing that?
Yes. So we know basic things, right? Like we get data from continuum of care on like people who are experiencing homelessness, how many days people are spending in shelter, that kind of thing when they do their live counts and any reporting they have for their funding. What I feel like we would be beneficial for a lot of us moving forward is understanding like, okay, where are the differences in like, or what are their challenges related to accessing healthcare, for example, since that's one of our priorities. How, are they able to get access to mental health treatment, substance use treatment? Kind of, are there rates of disease that we already look at for our population overall? Like, how much of a disparity is there between that population? So it's more like the very granular, like nuanced data that I think we don't have. I think we understand like how many, people are in our homeless population, that kind of thing. But to your point, I do think that if there are local data sources from community nonprofit agencies, social service agencies, that I think there are ways that we could use that somehow or better. I don't know. And it's something that I think newly we will be trying to do in the next 3 years.
Well,
Becky,
I
I'm
don't want to
wondering.
put Michelle on.
Go ahead.
I don't want to put Michelle on the spot, but this is an excellent opportunity for you guys to meet. And since they're collecting a lot of this data, you may want to consider using some of the information that they're collecting. Michelle, is that okay?
Yes, that would be fine. And we can, I know
Okay.
we have an agenda today to get through, so we can certainly talk more about that too, if you're interested, Becky.
I want to jump in and note, and this is also going to be a kind of a transition, Jan. Mary's not able to unmute today, but there is an extensive collaborative data effort regarding the continuum of care that we don't have time to kind of unpack it today, but another time that might be a really good place for us to take a look at what's the disaggregation that's happening there and how does that relate to what we want to learn.
The leaf blowers are temporarily quiet, so
Hooray! Okay.
I know we need to move on in the agenda, but coming up soon, within the next couple of months, we will have the results from our community needs assessment that we do for the community services block grant program that Northern Illinois University has done for us. It included surveys that went out to like random sample addresses within the community, with a heavy weight on lower income populations. It includes focus groups, it includes stakeholder information, stakeholder surveys, client surveys. So it's an enormous data collection it's specifically on community needs, and it does ask questions about access to different types of programs and services. So we'll have that soon, and obviously we're excited to share that with others.
Thanks, Mary.
Mhm.
And I want to say, Becky, thank you very much. And I want to note that HEART, our group here, has a stake in those priorities. We were in the Forces of Change assessment. We promoted the survey throughout the community to understand individuals expressing their needs. So we want to be on board, and we want to put our flavor into those priorities going forward. That's a great segue to introduce an opportunity for us to do some collaborative planning. And I want to invite Kara to describe what's in front of us.
Great. Yeah, I'm actually really excited to talk about Arise. I'll say one more thing about Impact DuPage, because we're literally at this moment working on identifying our, not the main priority, but some of the ways that we'll measure success and progress in that priority. And it's worth doing well and thoughtfully to ensure that we are adequately collecting information that others are already working towards within their respective organizations, and also to look for opportunities for collaboration. I don't feel like we have enough time in this meeting to get where I want to go there. And I really feel like it's so important that, since we're going to be working on these objectives for 3 years, that we cast a wide net and be really inclusive in that data tracking. So I'll figure out a way in the next week to reach out to our HEART partners to try to invite more discussion on that topic, because it's really in the course of the next several weeks that we're likely to be setting some of those goals for the next 3 years. So,
and Kara, if I
though,
could,
yeah,
quick
sure.
context. When you say we, I want folks to understand that you co-chair the Impact DuPage Coalition. So you've got a couple of hats that you're working here today, and you were Becky's partner in this presentation.
Well, and there's a host of Impact DuPage members on this call, and as we all know, we're really just a group of about 50 people that go to a bunch of different meetings together at different days of the week. So this is really a shared community effort. I know that Fabi is participating. I know Dave, you do. Mary, you do. Faye, I think you have, certainly Access does. And so this is something that we all create and co-create together, and we want to make sure, especially given the experience we've had in the last several years, that we are taking careful stock of how we measure progress for the next 3. But that will be the transition to an exciting opportunity. And I'm going to ask Becky, if you can you pull up the RFA for the Arise grant? So several weeks ago, a number of us probably received one sort of notice of this potential funding award or other. And what was interesting to me is I got notice of it probably from the state, but within the day that I got it, got emails from 3 or 4 different HEART members and colleagues thinking, wow, this really looks like a project that's perfectly aligned with HEART's work. And what we're looking at is a project called Arise, which is under the mnemonic, Activating Relationships in Illinois for Systemic Equity. And this is an Illinois Department of Public Health, Center for Minority Health Services funded project, also partnering with Office of Rural Health and an organization called We in the World. And it's really around identifying motivated communities that have experienced historic and present day inequities. That would probably be every community, but communities that are taking some collective action on that topic to give them some additional support to advance community resilience, well-being, and equity. This is actually a CDC funded opportunity, and it's specifically targeted to communities in Illinois except DuPage, Cook County. Cook County has different funding. So everyone but Cook is eligible to apply for this award. And 15 community collaborations are intended to be selected. A community collaboration is pretty loosely defined, 3 or more partners. Of course, HEART is comprised of many more than 3 partners. And then also the invitation is to include their associated health department. But of course, again, here in DuPage, our health department is already intimately connected to this work. And in fact, in many ways, the backbone for it. The opportunity is that this is a little misleading, I think, the way it's written. They have an opportunity to receive up to $235,000, but the way that actually works is that in the first 10 months of this, if awarded, 15 organizations will receive $100,000, and then their health department $35,000 in addition, so a total of $135,000 in year 1 or months 1 through 10. And then there's an opportunity for renewal for organizations that demonstrate progress for an additional $100,000 for, I presume, a second year. There are also opportunities for communities to apply and perhaps not receive one of those 15 larger awards, but be eligible for smaller micro grants. And what you're really applying to do is to participate in a 10-month learning and doing program, and really helping to map your current state and also identify opportunities for improvement, both the maturation of your collaboration and also your goal setting and achievement of those goals. And so you'll receive some technical support and have the opportunity to collaborate with other cohorts that are doing similar work around the state. And there is definitely a COVID acknowledgement in this planning, but it is not intended to explicitly or solely look at issues around COVID-19. It acknowledges them, but it's sort of part of why I think this is such a good opportunity for HEART. For many of us, I think COVID provided a crisis that brought us together in ways that perhaps we hadn't worked in the past. But if COVID were a distant memory, it isn't, but if that were to happen, we would still be left with pronounced health inequities that we would want to continue to work together on addressing. Can you scroll down a little bit, Becky, to go into the geographies portion? Okay, so the thing to note is that this is an Illinois-wide application process and does not include Cook County, but they have focused and identified some communities of priority, and DuPage is not one of them. So the one bit of disappointing news is that we are not one of those prioritized communities. Those communities were identified by having low rates of vaccination and high rates of social vulnerability. And the relative affluence of DuPage County challenges on a county-wide basis a high social vulnerability index score, even though we absolutely have communities with high social vulnerability. And we also have fared comparatively well against the state in terms of our vaccination rates. But as Dave mentioned at the very beginning of this discussion, we also have, because of the fact that we are a large county, if you look only at rate, it obscures the actual impact on individuals. And we have had pronounced loss of life and loss of quality of life regarding COVID, and unfortunately with a host of other issues as well. what we are considering and what we want to invite our heart partners to join us in is to submit a shared application. The application, let me break out what we want and then separately what they ask. From our perspective, if we submit an application, we are submitting an application for heart, including all members of heart. Now, the technical requirements of this application process are that there would actually be a limit of naming only up to 10 community organizations. And we are blessed to have more than 10 community organizations that are actively participating in this process. So whatever we put into that application is frankly irrelevant to what we actually intend to do as a community, but we are open to the explicit inclusion of up to 10 of our community partners as named partners in this enterprise. The application process, there were a number of informational sessions over the course of the last few weeks that a number of folks on this call have participated in. It's not an unduly onerous application process, neither there is an opportunity to help provide some stipend to some of our community partners for their investment of time and energy in this enterprise. So that $100,000 that would be available to, if awarded, would be intended to go to some of those community partners that are willing and able to invest time and resources in working toward these shared goals. But the first piece, and one of the pieces that can differentiate our application from some others, is broad scale participation in an assessment process that has been launched. And I think, Becky, if we can put a link to that assessment in the chat, that would be helpful. We will also follow up in an email to include that link in an email to everyone who participates in HEART, not just folks who are on this call today. But Dave and I have already completed that assessment because we wanted to know what we were describing for others and what we were asking them to complete. And I wonder, Dave, if you would be willing to share your experience. I want to lead with saying that the funders were very clear that this assessment is intended to set a baseline for where a community is today in their collaborative process. And the answers to that assessment have absolutely nothing to do with whether or not we will be awarded this funding. This is not a goal to have our scores be higher than we might otherwise find them in a way to make us more competitive for the process or the opportunity. This really is just to ask the honest question, where do you think we are as a community so we can set some guidelines about where we want to go? Dave, tell a little bit about the assessment more broadly.
Sure. Kara, I think you said it really well. It's establishing for us a baseline of the opinion in our community regarding how well we're doing on equity in concrete ways. And so in a year, we would want to take it again and determine if we've made progress. And it's expected that we're going to have diversity in the responses. It's going to look different to us depending on our perspective. And that information is its own value. Where are some of us missing the boat that others of us can grab us and say, hey, pay attention. This is an area that needs a focus. So it took me about 15 minutes. And I believe that what the potential funders will take into account is how well we're able to gather this input. And the commitment from members here would be to complete an assessment like this organizationally, but also to select your own constituents to share it with and look for some informed, engaged constituents in your group to get them to weigh in as well. The truth is, we don't know if this is going to bring us the funding, but it's going to bring us good information to plan on. And it's going to help us establish the direction that we need to be going in, regardless of what the state decides about funding. So it's, I believe, a win-win.
Yeah, there are 6 categories that they're asking questions about, and it's a handful of questions in each of those categories. I think there were about 30 questions altogether, and I agree with Dave. It took about 15 minutes, and really it's a scale where you're assessing where we are from. Oh my gosh, we have a whole lot of work to do, or we've got that one knocked out of the park, sort of. And I think it's actually 10 points on each scale. Yeah, it is. And it was very interesting. They give you the results of your own scoring right away. So you have an opportunity to sort of contextualize the answers that you gave. In addition, with the link that Becky shared, all of that data then gets aggregated back and becomes a piece of our application for this funding. I think that it would be excellent for us to have really strong participation in the assessment process. Again, the data would be helpful to us, separate from whether or not it helped us to secure the funding. I think what is a little less clear to me is how close you have to be to Heart's work to feel comfortable speaking to some of the questions on the assessment. I feel confident that if you're someone who has participated in at least intermittently Heart meetings, you are in a position to respond to this survey. There may be members of your team who are very interested in health equity, but may feel less positioned to respond to some of the questions around the collaboration. And so we would defer to your judgment on that piece. But the application is due at the end of June, and we will be following up to invite all Heart members who wish to be considered as potentially being a named member of the community application to indicate as such, and we'll set a follow-up meeting in the next 1 to 2 weeks to have some more discussion. Organizations that are named can be recipients of a portion of the funding. Again, if you divide $100,000 by 10 organizations, we want to rightly scale the amount of funding available. But separate from that, if we are awarded the funding, we would certainly hope that it would serve all of our aims, not just those who are named within the application itself. Becky and Dave, anything else that we need to talk about in regards to this opportunity?
Kara, I would want to add one thing, that
Yeah.
one of the issues that we know we've faced as a community is providing financial support to the health promotion and health protection work that's being done by community organizations. And there has been some boosts through state funding, which are going to come to a close. Some already have. This particular project that we're looking at isn't going to restore funding, but it's going to give us a roadmap to be able to draw new funding in. So I want to put that out there, that we're taking the long view, and this should take us to a place where we will be better able to sustain our community organizations.
Yeah, I'm really glad you mentioned that. I think it will also give us a bit of a structure and some subject matter expertise in helping to evaluate how we make that pivot from the work that we've been doing almost exclusively focused on COVID for this last 2 years to the next phase of our collaborative efforts together. And so for that reason, I would really be excited for the opportunity to have that support to sort of bolster the efforts of folks who came together organically because we recognized that it was a place to invest our time and energy. So more to come, follow-up emails, but the most pressing time-sensitive component is to begin that process of assessing where we are, and then for us to invite our community partners to participate in a more significant way in the application process if they're so inclined. Thank you very much.
Thanks, Kara. Okay, well, I'd like to move us now into our next agenda item, also a forward-looking agenda that draws on our experience in the last year. And Tim, we're going to talk for a minute about the Middle Eastern North African data project. And I want to give a heads up. In this team right now are community members who are concerned about the way your constituents are represented in data. The data we've been collecting here regarding COVID and the excellent disaggregated presentations that we've seen, but also what you saw Becky present from Impact DuPage. And you have a stake in how is your community of constituents represented so that you know what needs to be done. Also here on our team, we have healthcare providers and public health monitors who are trying to figure out what's the best way for us to collect data. It's not a simple thing to understand what categories we should use and how those can be sustained and consistent across entities and across systems. So you two groups, I'm going to make a pitch to you when we finish this to say we need your engagement with this project. By way of background, early on in our life, we were watching fine data disaggregated presentations around case counts in COVID, morbidity and mortality. And Dr. Saima Asfar early on looked at that data and asked us, where's my community? Where's the Middle Eastern and North African community represented? How do we know how that status is? And it was early days, and we continued to persist through. And when the vaccine became available, we also began to get reports on vaccination rates. And that also is disaggregated. And once again, Dr. Asfar came back and said, where is the Middle Eastern North African representation here? So we, as a work group put together, as a team put together a work group to look at that issue. We talked to some experts, we put together some recommendations, brought them back to this group and determined that, oh my goodness, it's a lot more complicated when it comes to establishing a standard for collecting this. We need to get some more process done to do this well. And that's what brings Tim Ackerman to us from Northern Illinois University. We have a commitment from ICNA Relief and its extensive engagement with communities that are Arabic speaking, that identify as Middle Eastern, North African, or as Southwest Asian. And this project is going to do this. It's going to create a partnership between communities that want to know what their health status is and what they can do about it, and those providers and monitors and researchers who collect data. We want those groups to be in sync so that we're getting the best data possible to make plans. And so Tim's project is to, the core of it is collecting information directly from the community affected regarding their preferences, regarding identity, and that information informing health systems, public health monitors, and researchers to do that well. So my pitch today to all of you, if you're representing a constituency that you want to see represented well in data collection, support us in this project, be an advisor with us. If you're in a health system that's collecting data and you're looking for a better way to collect things that are going to be helpful in the community, support us, come and advise us on this project as well. Tim, could I invite you to kind of fill in gaps? What did I miss that's important in this project?
I think the first and just most important thing is just finding out the best ways to accurately represent people how they want to be represented, not just, well, let's just add a Middle Eastern / North African, box to all the, data collection tools, but find out how they want to be represented, how it's going to best help them and help us, and just everyone work on problems that we currently have in our systems.
Thanks, Tim.
Mm-hmm.
So this is my invitation to members of this team. I also will send a note out to you inviting you with a kind of a description of what the project is and how you could help us in the advisory way. And I hope that you will give that consideration. I appreciate Tim's willingness to be with us. He'll be with us until probably the middle of the fall. And at that point, we're hoping that we're having good conversations with healthcare providers based on information from the community that identifies as a Middle Eastern, North African, or whatever we learn from them about their preferences. Questions, comments, thoughts? Okay, then I want to invite Chris. I believe I'm inviting you for a COVID-19 update.
Yes. Hi, Dave. Hi, everybody. Can you hear me okay?
Yes.
Okay, awesome. I know we've got just a few minutes, so I'll hit some highlights, and then as usual, share all these slides with you. The goal is trying to put together what we know about COVID today and try to aggregate that in one place, because every month it gets a little bit more complicated now. You'd think that after 2 years of COVID, we'd have this down to a science, and yet the one thing we've learned through COVID and experienced is that things continue to change and we have to change with them. So Dave, can you see a full screen or a presenter view?
Full screen.
Okay, perfect. So we today continue to be in what CDC considers that high level of community transmission. And if you remember back maybe 2 meetings ago, we talked about the changes to CDC's breakdown of how they rate communities, and they have low, medium, and high. High being the highest level of case activity and hospital associated impacts of COVID infection. So as of last night, these get updated once a week. We in DuPage County are in that high level. And I drew some pretty crummy looking lines to try to explain how they do that. The first is that our case rate, the number of new cases that are identified in the community every week, is higher than 200 per 100,000 residents. And that rate allows us to compare the number of cases in DuPage to those in Cook County or a smaller community. And that's why we use the rate and not just the raw number of cases, because our populations are different size. So we have more than 200 cases per 100,000 residents. And right now, the number of new COVID-19 admissions to our hospitals per 100,000 population is over 10. It's at 11, so it's not hugely over that level, but it's at the level that puts us at high transmission. And those numbers are staying kind of stable right now. We have always, through COVID, seen hospitalizations occur a few weeks after cases go up. So we had been seeing a really significant rise in new cases from the end of February and March, when we kind of bottomed out after that horrible December, January. Cases have been climbing. Thankfully, cases have actually started to go down over the past 2 weeks, but it takes time for those hospitalizations to emerge. People get infected, they get sick enough to need to be hospitalized, or they're in the hospital for something else and get tested. So we are concerned that people who have COVID are in our hospitals. It means more PPE. It increases the risk of transmission to other people in the hospital that may be there for some other reason. And it also means that staff may become infected, not able to work. So this is still important to monitor and pay attention to, even if we don't see as much disease as we had or as much hospitalizations as we did in the past. By virtue of the fact we're in high, these are the individual and community level prevention steps. So I highlight these just to provide some support and rationale for why we want people to take more steps when cases and hospitalizations are high. Now, again, the good thing, and you'll see in a couple slides down, cases are starting to decline, but anytime cases start to increase, that's the time for these protective measures. One thing that's not great about these community levels from CDC is that we didn't hit high until our cases had already peaked. And so by the time you hit high, it's not too late to make a difference, but it is much later in the game than we would like to have these protective actions taken. But it means that they're still useful today. So while we're in high, the recommendations that people wear a mask when they're indoors, especially in public settings where there may be lots of people. More and more often now, we're seeing events of hundreds or thousands of people packed inside, and there's very few people wearing a mask. And that, it's a personal decision, but the risk to those around you or around people who may not be choosing to wear a mask does increase as the number of cases is higher. People can still be asymptomatically infected. There are more people in the community we know who are infected right now. And so we just want to make sure that there are ways to prevent that systematically. Staying up to date on vaccines, critically important. Vaccines have provided such tremendous benefit against hospitalization and death, and is really helping us to get to a point where cases are important, but if we can stave off severe illness, it's even more important. So the summary of prevention measures is here. If you are in charge of a space or have a say in what policies your organization, your event, your facility puts into place, these are a really good menu of options for you to consider. In high, we want to have more measures than less, but any number of these can contribute to decreasing transmission. More of the country is seeing increased transmission. So this just looks at early May to early June. On the bottom right side is where we are today, and you can see that more communities across the country are seeing higher levels of activity. And if you watch the national news, you see those national numbers are going up too. Another way to look at this, I like this one because it, regardless of what qualitative level we're in, this just breaks down case activity, and the scale is a little hard to read, but ranges from green all the way up to that dark maroon red. You can see that right next to the map of the US. You can see that there's a lot of case activity right now. And while cases are maybe less important than they were early on, because a lot of people get infected, they have a minor illness and they're back to good health quickly, every new infection poses a risk of infection to those around those people. So really important to pay attention to those cases and try to prevent transmission in the first place. Here you can see just at the very right tail of this, we are seeing our cases go down over the past 2 weeks. So that is really, really encouraging because that hopefully means that we'll see fewer hospitalizations and fewer deaths a few weeks out. But we hit a really high level of case activity relative to the rest of the pandemic. It pales in comparison to what we saw in December and January. So it's easy to say, well, at least it wasn't that bad. And that's absolutely true, but that was really bad. And if you look at where we were in May, it really is higher than we've been in most points of the pandemic. So we want to try to avoid these surges going forward. In terms of ages of those impacted, we have thankfully seen kids, the 0 to 19 group, drop off a little bit. They have been leading the pack in terms of number of new infections reported, and they have fallen below the 40 to 59 and 20 to 39 age groups. So starting to see more people in that 20 to 60 year age range being infected than other groups. So really important when we think about messaging on prevention steps, those are the folks that are being infected right now. The other important thing to note about cases, I'm going to go back to this one right now. Right now we're seeing about 394 cases reported per day. That's probably a vast undercount. When you think about the number of people who are testing at home and don't go on to get a test from a healthcare provider or may not test at all because they don't have access to tests or they choose not to, there are more and more cases out there that we do not know about. So what's really important here is the trend. When we see cases increasing, we know there's more out there. When we see them decreasing, we're hoping that that overall trend is down, but important to recognize that we do not know about every case that's out there. And that's okay. We'd love to know more about it. The important thing is that if somebody tests positive, you, a loved one, a family member, a friend tests positive, 2 things to do. 1 is to isolate, stay away from other people so you don't transmit that infection on. And 2 is to let your healthcare provider know. There are lots of treatments that are available, but you need to work through a healthcare provider to get those. And that won't work unless you share that positive result with your provider. So we've talked about that here. I'll share some resources later on, just kind of helping explain that, but really, really important. In terms of the variants, this is probably the most important thing to know and think about going forward is that COVID doesn't stay the same. And what's so important is that these new variants, the more infections we have in the community, the more likely it is that the COVID virus, the virus that causes COVID will change just a little bit to be better at transmitting, to evade the vaccine protection, to evade immunity from a previous infection. And so that's why things change. And I think people get frustrated. I know people get frustrated and say, well, do we really need to worry about this anymore? And the answer is yes, kind of. As these variants emerge, they may be very different than what we've experienced before. So just because you were infected 8 weeks ago may not mean that you have protection for more than 8 to 12 weeks. You could be up for risk for another infection if a new variant emerges that evades that protection. So it's not as important to know each strain and what number it is than to recognize that these new variants will emerge and means that we do need to continue to take some protection, some precaution to prevent transmission. On hospitalizations, we are seeing a rise in hospitalizations. Thankfully, we didn't see that rise to the level of January. Our data here on this chart counts only hospital admissions that are really due to COVID illness. So when you hear about, well, is that a hospitalization for COVID or is it just with COVID? Did they have a broken arm and they got tested and they happen to be COVID positive? Our numbers and our communicable disease and epi team and Dr. Chug and her staff really do try to drill down into these to understand which of these hospitalizations we're seeing are due to COVID. And this data on this chart reflects those. The other data we've shared previously with you that shows hospitalizations that reflects anybody that tests positive in the hospital. And we see those numbers rising as well. And so again, we are seeing those impacts in our hospitals. I know we're short on time, so I'm going to skip some of these, but trust that I'll send them to you. And if you have questions about them, we'd be happy to follow up. Some really good news is that we're seeing a much smaller number of deaths reported related to COVID infection. We have seen, it kind of bounces around. It's still 1 or 2 a day. It's not where we were last summer. We have, look back in the middle of the chart towards July of last year, we had like 3 weeks with 0 deaths reported. We also had really low case activity at that time. So we know we can do it, right? We've been there before. We can prevent infections, and we want to try to prevent illness and death as much as we possibly can. Vaccines and vaccine boosters continue to provide a really high level of protection. I think this message too, anything we can do, and please let us know how to work with you or with communities to share this information. Just look at the numbers on the left side. People who were unvaccinated had almost a 5 times greater chance of being hospitalized due to COVID-19. And those numbers range from 2.5 times more likely in adolescents who are 12 to 17 who are not vaccinated, all the way up to 6 times greater in adults over 65 being hospitalized if they were unvaccinated. So vaccines continue to provide really, really important benefits to folks. Since the last time we met, CDC and FDA updated their recommendations on boosters. They added the ability and recommend now that anyone over the age of 5 should get at least 1 booster after completing their first series. So important for that 5 to 11-year-old group that may have been vaccinated in the past year. I have kids in that age group. I will get them their booster. We know that that's an important level of protection that we can provide. The health department started doing those boosters just this Wednesday, so we are able to provide those to folks. We would be happy for you to refer patients or clients here or any number of other sites that are doing those boosters. Just really important to offer that protection to those kids. As you've seen in the national news, the next big milestone is that vaccines for the 0 to 4-year-old population. And FDA has announced that June 15th is when they'll be meeting to review Pfizer and Moderna's applications for emergency use authorization of their vaccines for that group. And CDC meets, I believe right now they're scheduled to meet the following week. So it could be as early as late June that we see vaccines available for the 0 to 4. So any messaging or help that we can provide or work with you to help parents watch for that information, know what to do if it is available, is important. And for the 5 to 11 group, I think just important to note that we still only have about half of those kids fully vaccinated. So we know we've got work to do, and even that population that's been eligible for over 6 months now. So we know that this will be another opportunity when those 0 to 4 vaccines, if they become available, to really message to our parents and community that these vaccines are available, they're effective, they reduce the risk of severe illness. We are able to go out, sorry, let me get to that slide, with the caravan. Other healthcare providers have same opportunities, but if you think there's an opportunity to partner with us over the summer, especially with events and places that people will be, we'd be happy to bring the caravan out to do these boosters. An update on testing. As of the end of May, our site at the Odeum closed, so we are no longer testing at the Odeum in Villa Park. We continue to sponsor a free testing site at the DuPage County Fairgrounds. That's on the left side of the screen here. And then you've got a link on the right side to other test sites around DuPage County that are able to test for COVID. So just continue to share this information. Testing continues to be important, whether you're going to be spending time with somebody at higher risk or you've got symptoms yourself. We want people to take advantage of those testing resources. On treatments, these are the posters, the fact sheets I think we shared last time. They're available in a number of languages, so please share these where it's appropriate. This is really important for people who may have more severe outcomes from COVID or don't know that they're going to be at higher risk. If you have symptoms, get tested. If you test positive, make sure that you share that with a healthcare provider right away so that you can get access to those treatments if they're indicated. CDC has some better, I think, information now about treatments and medications that are available in a number of languages. So feel free to draw from these. If you click on these, it should take you to the CDC page. And these two will help explain and share the resources that are available about treatment. And last, stuff. So we want people to have access to tests, to masks, to vaccines. COVID.gov is a good kind of one-stop shop for those. People can request up to 8 home tests for free through there. Just put your address in, they come through the mail. There's no identifying information other than your name and your address that's needed. So a very easy way to get access to tests. Most insurance plans, including Medicaid and Medicare, now provide free access to at-home tests. You can walk into a pharmacy, give your insurance card, and walk out with up to 8 tests per covered person per month. I've done this a couple times. It gets easier every time I do it. So please share that with people. These tests are increasingly available, but they don't do any good if you're trying to scramble and get them when somebody comes up with symptoms. Take the time now to have them at home, know how to use them, so that if you have symptoms or somebody in your house develops symptoms, you can use those. And finally, we will continue to offer free at-home antigen, the rapid tests, and high quality KN95 masks to community organizations. So if you're on this call, want access to these to distribute to your parishioners, your clients, your whoever, let us know and we can get these to you within a couple of days to have you distribute them to community members. The very last thing I'll share is just another resource. There's so much information flying around now, and it seems like it continues to increase the amount of bad information out there that's downright dangerous in some regards, telling people that vaccines are dangerous, or testing isn't needed, or treatments are genetically modified. This public health communication collaborative, if you're interested, is a really nice place to kind of fact check things you might have heard and to find some resources that will help you address those. And so just as you see stuff floating out there, and have questions about it, feel free to reach out to us. Feel free to use this information. We want to bust those myths as much as we can and provide people good, accurate information to really keep them safe and healthy. So I know that was a lot. I will post the slides here. We'll distribute them. The goal, as always, is to try to package stuff together so you don't have to go scramble to all these different places to find an update. And happy to answer questions now, Dave, or follow up afterwards.
Sure. Art, any questions for Chris? And Sue, we will get you into the distribution. Thanks for that request. Chris, it's a fantastic collection of information. And what I do when I listen to you is kind of sort through what are the 3 or 4 messages I want to get to our constituents. So we'll do a follow-up when this is over. And I encourage everyone here to think about that. I bet as you are watching that, there are 2 or 3 things that just clicked your buttons, and you know that those are helpful for your community. And that's a great segue for me also to say to everybody, thank you for your work to promote vaccine confidence. I paid a special attention, Chris, when you showed the percentage of children who've been fully vaccinated in DuPage. And if I saw that chart correctly, DuPage County is at the top of the list of Illinois counties for 2 doses with children. And that's incredible. And that's a tribute to the work of groups here who are building that confidence in the community. And it shows in our performance as a county.
Definitely. That's work collectively here through this group. So if there are other opportunities we're missing, or you think there's something coming up with those kids becoming eligible, be happy to work with you or share resources.
And thank you. Your PowerPoint is now in the chat, so people can grab that as we close off here. I am going to bring us to a close, and I want to kind of recap a couple of things. Becky put forward priorities for DuPage County, proposed for our next 3 years of work together. She put together some data feedback to you that also came from the health rankings. Anything there that caught your attention, good, bad, or other? Feedback to her, your reactions. Let her know we have a stake in these plans. We've been engaged from the start, and this is a good time now to do the double check. Are we on target? Number 2, expect a communication from us regarding the ARISE planning opportunity. And please especially think about within your constituents, who are people that you think would be appropriate to take that 15-minute assessment of the performance of our geography in promoting health equity. Third, look for a communication from me regarding the project to engage Middle Eastern North African community and build partnership between the community and healthcare providers, public health monitors, and researchers. Thanks all so much for what you do. We don't have another date scheduled, so please keep an eye on your email for a calendar. Dr. Chug, very good to see you. Thanks for joining us today. And I pronounce us adjourned.
Thanks, Dave. See you.
you all.